Ms Hands.
Good afternoon, my lady. May I please call Mr Paul Featherston?
I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence that I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Thank you for coming to help us, Mr Featherston.
Mr Featherston, you're attending today as the chair and founder of the National Association of Care Workers, or NACAS, is that right?
That's correct.
And in addition to the roles that you hold within NACAS, is it also right that you have worked as a support worker in domiciliary care and provided care to your mother who had dementia?
That's also correct.
And you have provided a statement to the inquiry, which can be found at INQ 30569-768. And within that, you have explained how it is informed by your own knowledge, the experience and evidence from NACAS members, including through 2 surveys that were undertaken. Is that right?
That is right.
Now, you have explained how NACAS represents and provides education, resources and training for care workers, both in domiciliary and residential care.
Yes.
And that includes nurses who are employed, self-employed or agency staff.
Correct.
So is it right to say that you do not represent care home providers?
That's also correct.
Now, NACAS has seen its membership grow substantially from around 4,000 in March 2020 to around 15,000 today. What do you think has led to such a fast and significant rise in membership?
Well, I think it's because of our mission statement. Our mission statement was to provide support, career support to the care workforce. The overriding catalyst for me to set up NACAS was to shine a light on the care workforce. And I think that the members see that they belong to something that is exclusively for them, and they get a lot of support and encouragement from it. So if I'm allowed to say this, I'm quite proud of the fact that we've gone, our membership has tripled in 3 or 4 years. And some feedback that we've had from members actually mention the fact that they are so pleased that they found NACAS and that they are happy to be, proud to be members. So yes, I'm very pleased of where we are now in the short space of time that we've been in existence.
Yeah. And I think you've said that NACAS is UK-wide, but is it right that the majority of your members are based in England?
That would be correct.
Do you know what percentage of members are based in the devolved nations?
This would be a loose estimate, but I would imagine 60% of our members are from England, and with the other 40% being split across the Scotland, Northern Ireland and Wales.
And you have explained in your statement how 2 of the key reasons why NACAS believes that there was a lack of resilience in the adult social care sector at the time of entering the pandemic are significant staffing shortages and public perception of the adult social care sector, along with a few others in your statement. So if I may deal with the first, what were NACAS's members' experiences of the shortages in the workforce as we entered the pandemic?
Well, I think they were genuinely worried that, I think there was genuine concern that could they cope? Pre-pandemic, I mean, it's well known that there are significant staff shortages even today. But at the start of the pandemic, it was an unknown, and I think there was a lot of uncertainty from the membership. But I think that uncertainty has been somewhat waylaid by the resilience of the workforce. They found a way, they coped, and they managed through what was a very, very difficult period of time.
And what do you mean when you say public perception of adult social care, and what was the impact of that during the pandemic?
Well, if I may say, I always describe the social care workforce as the invisible, visible workforce, because much of what we do is behind the closed doors, whether it's in a nursing home or it's in a person's own home. Whereas our National Health Service, the wonderful doctors and nurses, people can see what's going on day to day, but in social care, it's not. So that's the perception. I think people don't think about social care until they actually need it. So it's something we need to get changed. The narrative needs to change around what care working is. It needs to be seen as a distinct profession in its own right, along with our colleagues in healthcare.
And what impact do you think that perception had at the start of the pandemic?
I think, I mean, it's difficult to quantify the impact, but I just think that social care, because it's seen as the Cinderella service to the NHS, I just think that there was a misunderstanding of what social care stands for and what it is. I mean, I think that's probably the best way I can put it.
And you have described how the lack of resilience in the workforce at the start of the pandemic led to an increased workload and responsibility for those that were working in adult social care, and the impact that that had on their mental health, well-being, and the long-term retention and recruitment within the sector. So firstly, do you know if there was sufficient training and support for care workers to deliver the additional tasks?
As far as I'm aware, the training for social care, in my own experience, is hit or miss. One of the things that we provide as an association is access to better quality training. No, we like to think it's better quality training. I think that the workforce are reasonably well trained, well, better than reasonably well trained. I think they're well equipped to do the jobs that they are doing. In terms of the training throughout the pandemic, I don't have a particular comment about that, but just to say that the workforce do receive what I would consider to be adequate training, more than adequate training.
What about access to mental health support and well-being for staff during the pandemic?
I mean, again, that's one of the things that we were able to offer as an association is access to health and well-being support to the membership. We could give them access to counselling sessions and things like that, because without doubt, our members again said that they felt as though their mental health was deeply affected by working through that pandemic. So we tried to, as best we can or could, offer some kind of mental health support to the membership because it was needed.
When was that support available from?
I mean, where?
When, sorry.
It's always been a benefit of the association to get access to mental health. So it's been there from 2019.
And was there a lot of uptake for that support during the pandemic?
I can't give you specific numbers, but I do know from feedback from members they were very grateful they had access to that. And those that did use it found it very, very, very useful.
Were you able to provide it to everybody that required it or came to your service for that support?
Yes.
Another consequence of the staffing shortages that you've described showed through the respondents to one of your surveys where they reported that there had been changes to care ratios. And in your statement, you quote a NACAS member who said that terrible staff shortages meant that there were 2 carers and 1 nurse on night shifts for 48 residents for more than a year. Me and many others worked on this ratio. Were those kind of practices and experiences widespread from your experience?
I can only refer back to what the members have said through our surveys, and I would concur that that was fairly widespread during the pandemic, yes.
You also say in your statement that there are a number of systemic and structural issues that impacted the ability of the sector to respond to the pandemic. And you've listed 3 that you have deemed most noticeable. And I'd like to go through those with you today. So the first is that there was a lack of care sector visibility and representation within government. Where in particular do you believe that there was a lack of visibility? So was that central government, local government, or public health?
Central government, I personally believe that because social care was misunderstood, is misunderstood, and to some degree, I think it still is. There was that complete lack of visibility. It was all, at the start, it was all NHS, 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 and nobody was talking about social care, which was odd to say the least. I mean, they go hand in hand, social care and the NHS. But you would never have thought, in my humble opinion, that there was a social care sector at the start of the pandemic, because it was never spoken about. And it was quite frustrating to see that lack of visibility and lack of acknowledgement.
And I think you have included in your statement some of your members' responses to survey questions around this topic. So I'm at your paragraph 36 and 37, if that assists. But one of the questions in that survey was, did the government make the right decisions during the pandemic? To which 78 responded no. And several members reported that there appeared to be no long-term planning or strategy in government decision-making. And at paragraph 38, you have provided some examples from your members. Could you perhaps summarise some of those for us?
Well, I just think what you're hearing there are the voices from the front line, that there was no cohesive, what's the word I'm looking for? There was no cohesive communication, if you like. So I can only go on what the members are saying through their survey. They lived it. They were there. They were experiencing what the government was or was not doing. So I'm going to defer to our members, because, I mean, unfortunately, I wasn't active. I wasn't an active care worker during the time of the pandemic. So if that's what our membership are saying to us, this is what happened, I think we need to listen to them and learn from that. If that makes any kind of sense.
Yes, thank you, Mr. Featherston. One of the policy decisions that you have referred to in your statement is around the hospital discharge policy. So what was NACAS's view on the policy and perhaps your experience around its implementation?
Okay. I think the discharge policy into care homes was ill-advised at best. It was not a good decision to discharge COVID-positive patients into a care home. And we were able to play a minor part in bringing that into the public eye. As an association, we were contacted by Sky News to find out whether or not we had any members who've had experience of discharged patients coming into care homes. And we were able, through our network of members, to put the Sky reporter in contact with a care home provider in the southwest, and through that engagement with that reporter and that care home owner, we were able to play a small part in bringing that much more into the public eye. I'm not going to say here we were the cause of it or the reason for it, but we certainly played a small part.
Could you perhaps, if you know, tell us a little bit more about the experience that you were hearing from those care homes or from your workers directly?
It's just that they were just having to think on their feet as to how best to protect the staff within those care homes, whether it's creating COVID rooms and things of that nature. But they were absolutely having to think outside the box, if you like, to keep everybody as safe as possible. And that was coming through to us from some of our members.
Did you hear about any issues that they were having with implementing some of those measures, for example, like you've just said, around cohorting or isolating patients, residents that were coming in?
I don't have any specific examples to give you. Again, I can only refer back to what was in my statement from our members through the survey questions, but I don't have any other experience, knowledge or experience to share with you today.
Okay. And what about any concerns that you may have heard around testing before discharge?
Again, I think the members again were very concerned that there was no testing or very limited testing prior to discharging people into care homes, which looking back at that was nonsensical. There should have been a layer of protection provided before someone, bless them, who was living with COVID or suffering from COVID was discharged into a care home.
Turning then to another topic, and that's visiting of loved ones in care homes. You have told us in your statement how some of your members observed that the restrictions on visiting were different between care settings. Are you able to help us as to why you think that might have been?
Well, I think restricting visiting into a care setting in and of itself is a draconian measure. If you're caring for somebody with, for example, advanced dementia, they're already in a confused state, and not to see their loved ones, which may have been a source of extreme comfort for them during that pandemic, I would imagine it would have caused even more confusion. Why am I not seeing my wife, my husband? And I think if the care homes were allowed to think, not for themselves, but able to think, what can we do to the best of our ability to make people safe, that's the staff and the residents, and allow them access to their loved ones. I mean, it's fundamental that you'd want to be close to a loved one, especially at end-of-life care, for example. So I think to restrict access to loved ones into a care home, I think was extreme. I think there should have been more thought given to how it could have been done to allow people access to their loved ones. I mean, yeah, I mean, it's quite an emotive topic, but people should have had access to their loved ones. To me, it's fundamental. They should have had the right. And I think if the care homes were given that flexibility to be able, so if we did this measure, if we implemented that measure, we could let 1 or 2 family members in to see their loved one.
And you have touched there on the impact of the restrictions on the residents of care homes, but in your statement, you've also included some examples of the impact on staff. Mm-hmm. So if we may have on screen, please, INQ 30 569 768, page 18, paragraph 60. Thank you. Paragraph A, one respondent to the NACAS survey said that more emotional and physical support was needed from staff as the clients didn't have visitors to speak to or to do small things for them, which would normally be carried out day to day by family members, neighbours, etc. Clients were in a depressed state, which in turn affected their general well-being and health. And then at subparagraph B, another member said literally their whole family support was taken away and strained carers were left to plug that hole. Were those kind of views and experiences widespread amongst your members?
I'd have to say yes, it was widespread. I mean, if you could try and imagine trying to fill the gap of a family member, when that family member, I'm talking that family member, I mean the person actually in the care setting is no longer allowed to see that family member, but the care professional is now expected to fill that gap. That's going to have take a toll on their mental health, and understandably, because they are not family. I mean, they are family in the sense that they're there to provide the care and support to them, but they're not that person's flesh and blood. And to have those care professionals step up like that and be able to do that function, I think speaks volumes for our care workforce. I think they went above and beyond.
And picking up on that first experience there of emotional but also physical support as well. So is it right that family members or carers that are coming in will quite often provide additional physical support with tasks that burden then fell upon the care professionals?
Yes, I think that's a fair statement.
a slightly different topic, please, and that's access to sick pay and isolation policies. In your statement, you say that NACAS considers that the insecure nature of much care work and the absence of limited availability of occupational sick pay significantly impacted care professionals' ability to self-isolate and shield during the pandemic. Can you tell us a little bit more about the experiences of your members around their ability to self-isolate and shield, and whether access to sick pay informed or affected those decisions?
I do believe that the access or non-access to sick pay did influence their decisions. I firmly believe that a lot of care professionals thought to themselves, I can't afford to get sick because if I can't work because I'm sick, I don't get paid. So I think there would have been occasions where a care worker, not feeling 100%, feeling a little bit under the weather, would have gone to work because they needed to earn money, and because in some instances, there was no anything else other than statutory sick pay. They just made that decision that I need to go to work. I need to go to work to earn a living, and I need to go to work because if I don't go to work because I'm sick, I'm not going to earn anything. So it's a heck of a decision to have to make, isn't it? Especially in a pandemic. It's maybe an area that needs to be looked at in terms of sick pay, but they need to be able to make that right decision about not going into work if they're feeling under the weather. But I just think in that pandemic, in that situation right then, they made those conscious decisions to go to work because they don't want to let their clients down. They go to work because they care. Pardon, no pun intended.
Turning to the second systemic and structural issue that you've identified in your statement, and that is unclear accountability. Can you explain what you meant by that?
Well, I mean, I think it's just a general statement. There just didn't seem to be anyone or any one organisation taking accountability for things. Everything was done, and I hope I'm answering the question. I think everything was done in a rush. It was done almost reactively. There was no cohesion around the decision-making processes. That's the way I saw it. Others may see it slightly different, but that's my understanding of it. There was no clear organisations, taking a specific accountability for things.
And you describe a lack of integration and coordination between health and social care services and a fragmented structure in your statement. How do you think that impacted the response of the adult social care sector during the pandemic, and how do you think it could be improved in future?
Well, I think this goes to the heart and the nub of the matter. There's no parity of esteem between health and health professions and social care, and that needs to be brought up fairly rapidly, in my opinion. There needs to be absolute parity between health and social care and adult social care, so that the communication lines between those two facets are much better aligned. And if I may say so, it goes back to the visibility question that you asked me earlier. It would certainly raise the public's perception of what social care is, what it means, and what it means to work in it.
And the third and final systemic and structural issue you identify is inadequate regulation. Again, what did you mean by that in the context of the pandemic?
England is the only nation in the United Kingdom that doesn't have any form of mandatory registration. And I think had there been a register in place, any data held on that register, I think, could have been a massive fillip during that pandemic. That's where I was coming to then in terms of, that's where I was referring to in terms of lack of regulation.
I'd like to ask you some more questions about the register. Before I do so, you said there that data could have been a massive flip during that pandemic. Can you just explain?
Beg your pardon, I didn't say blip, I said
flip.
Philip. It could have been a huge asset is what I meant to say. Sorry if I said blip. I didn't mean to say blip at all.
No, that's okay. I think that might have been my mistake. But if I may just ask how it could have been a massive asset during the pandemic.
Is it okay for me to refer to my notes here?
Yes, absolutely.
So I get everything right. If there was a register, a form of register in England, then that data could have been made available to all the emergency services, the health, all the relevant organisations within healthcare. I mean, there's rapid deployment of information. If you've got a register with 1.5 million people on it, I mean, that's if everybody was on the register. You could just disseminate information real time, instantly. It would enable people to. There would be rapid deployment, so people with certain skills, certain attributes could be deployed in the right areas through the data on the register. There could be skills-based role making. There's direct communication, which I just referred to. I mean, to say one of the massive areas of support that the register could provide its registrants is that dissemination of information. So as the information is being made public, then instantly there's a scope there for us to disseminate that information to everybody on that register. So everybody gets the same information at the same time. I think that would be that alone would have been invaluable. And it would also provide an opportunity for people who maybe leave social care that were on the register. We'd still have that data, so we would still be able to communicate with those people to say, would you be prepared to volunteer your services as a former care professional and help out in this pandemic? I mean, God forbid there be another pandemic, but that's something that register could help to do. It would enable us to provide access to these people who may want to say, do you know what? Yes, I'm quite happy to blend my services during the pandemic. And that data held on the register could be a fundamental point to that. I think it's capable of doing so many things. It's not just a register of people or care professionals. It enables us to be able to be much more proactive in getting information out there and deploying the workforce where it's needed.
And who do you envision being eligible to join such a register? So, for example, would it include unpaid carers?
Well, at the moment, we are actually concentrating on the paid professional workforce. That's not to say that in future our work could look at extending that to the unpaid care professionals. But at the moment, we are just focusing our attention on the paid workforce.
Now, Mr. Featherston, when you say at the moment, do I assume from that you're referring to the care professional register that your organisation has helped to set up, the voluntary register?
Yes, maybe I should have said that at the outset.
Not at all.
So yes, we operate the care professional register. It's in a prototype framework at the moment. I'm pleased to say that through some hard work, we've been able to pass the Professional Standards Authority's public interest assessment, so that we now know that the CPR, to give it an acronym, is fit. Sorry, not fit. It does meet the public interest. So at the moment, yes, we do maintain that register.
And that will be a voluntary register for professional social care workers that are paid.
Correct.
In England.
Yes.
And what will the care professionals that join the register benefit? What will they get from joining?
Well, we see it as a statement of their professionalism, that they take accountability for their actions. They demonstrate that they are properly trained and qualified to carry out, can I call it the care profession? Because that's what I fundamentally, firmly believe it is. That it raises the profile of care working as a profession alongside the individual care worker. It gives a certain prestige, a gravitas to the work that we do. That's the royal we, because I still consider myself a care professional. It's a public declaration that I care about what I do. I am a professional, and I'm happy to have an entry on that register to demonstrate that. I mean, it improves employability. It's so much that being on a register does. It's not about control. Again, registration is about protecting the public interest, and that public interest is better demonstrated through a person who takes accountability for their.
And just, if I may, what information will be recorded on that register? So I think you've alluded to perhaps qualifications.
Yes.
Personal information, ethnicity, those that kind of data as well?
We do capture that data, but that data is not shared if the register is searched, if you understand what I'm saying.
So it will be available publicly to be searched?
It can be, the register in its present format can be searched, because, for example, if we went onto the register website and put my name in there, it would show up my name, whether I'm active in the profession, and what training I've done. It doesn't, and my PIN number. It doesn't display anybody's personal information or their ethnicity, so that would be wrong. But the only information that somebody needs to see is what's their name, are they qualified, what training have they done, and are they still active on the register? And then they can make an informed decision then.
Forgive my interrupting. I understand this is a voluntary register, and you've set out very clearly the possible benefits to your members. I have heard an argument to suggest that if you had a mandatory register, that might discourage some workers from entering the profession.
I do think that's a valid point. It does have some credence, but to me, speaking personally as a care worker, I think it's right that there should be some kind of mandatory element to it, especially if you're declaring yourself to be who you are, a professional. I think I've heard those comments around the possibility of the workforce being depleted because people don't want to go on a register. But I think that's one of the challenges. We need to form the register in such a way, milady, that it doesn't create barriers. So it could be that we have a tiered type of register, so people brand new into the sector, people who are more experienced, maybe have completed all their mandatory registration, and then maybe a higher tier for those who have got significant experience, training and/or an educational qualification. So that's our thinking on how we could reduce the barriers. And the thing that hasn't been mentioned, but I think I should mention, is the cost. We wouldn't want the cost either of registration to be a barrier, but at the same time, any register would have to be sustainable. So we are mindful of that, and when we're thinking about setting costs, they would be at a level that would be, we think, manageable to be able to, not to detract from people wanting milady to join the register. But I do take the point.
Thank you. Moving on to a different topic, Mr. Featherston, and that's IPC measures and PPE. So one of the IPC measures the inquiry has received a lot of evidence about is the restriction of staff movement, which you've addressed in your statement. So starting, if I may, with what NACAS's views and its members' views were on the guidance and timing of that guidance around May 2020.
I do apologise. Could you just repeat the question, please?
Yes, of course. The topic is around restriction of staff movement.
Yes.
And guidance was issued around May 2020. And I was asking what your members' views were on the guidance and the timing of the guidance.
I think the members' views of the guidance was mixed. I think it was that there was either very limited, or it was it's either limited or it was changing too frequently. I mean, from my experience receiving feedback from the members, it was that they couldn't get access. They couldn't get access to stuff like the PPE that would improve their, I can't think of the right word, improve their protection against contamination. But I think generally that they felt as though that the guidance was either out of date or it was not relevant, but it was too ad hoc.
Are you talking about the PPE guidance there, around IPC and PPE?
I mean, I think that's included in it because,
Okay.
as part of the infection prevention control measures,
Yeah.
one would expect to have access to the appropriate equipment, protective equipment. So that's where I was coming from there.
Yes.
If I've misunderstood the question, I apologise.
That's okay. I think in your statement you spoke about your members reporting mixed views on restrictions of staff movements, so we have that there. Did NACAS play any role in advocating for any changes to the policy or guidance around staff movement?
I beg your pardon. In terms of restricting movement through social care, one has to recognise the intrinsic nature of domiciliary care work, so it would be difficult to restrict movement in that setting. But I think in terms of restricting movement in care homes, that would need to be carefully thought through as to how that would work. In terms of staff flexibility, providers wanting flexibility, and things of that nature. So I think a blanket ban would be inappropriate in terms of staff movement. There needs to be, just to say, right, stop, I think that's a complete, no, I don't think that would be appropriate.
Okay. You mentioned there around access to PPE, and you've told us in your statement that NACAS bought and distributed 2,000 disposable face screens.
Yes.
Just to clarify, were they face masks or perspex screens?
They were perspex single-use screens. The reason we did that was I was getting regular calls from members to say, I can't get hold of PPE. So I just took it upon myself to try and do something about it. I felt almost like an obligation to our members to try and do something. So we purchased a quantity of those masks and shared them out on a first come first served basis. I mean, that didn't even scratch on the surface, but I just felt that we need to try and do something to help them.
Did that distribution include to people that were working in care homes and domiciliary care?
Yes.
Okay. I wanted to ask you about some of the feedback you received from a NACAS survey around training about for COVID-19 and the risks that workers faced. We don't need it on screen, thank you, but in a questionnaire that NACAS put out, approximately 47% responded that they hadn't had any training. And 87% that did receive training said that it did not include information about a potential enhanced risk to ethnic minorities. From your members' experiences, was there widespread training around the risks for COVID-19 in the adult social care sector?
Not that I was aware of. I can say, my lady, to this inquiry, that one of our corporate members did put together a COVID training package, which they made available to our members should they want to access that. That is the only example I can give you where there was specific training for COVID. But that was something that was done in-house through our corporate partner.
Do you know when that was made available?
I would say around about 2021. I'd have to come back to you with an exact date. It should be fairly easy to find.
Thank you.
Because it's still on our training platform.
And perhaps this is an obvious question, but do you think that it would have helped if there had been more training and support available to
definitely.
members? The final IPC measure I wanted to ask you about was in regard to testing and whether your members reported any issues around access to testing or issues with following the testing regimes that were introduced.
Certainly had instances where members not been able to get access to testing kits. Again, this was something I tried to do something about. I tried to get onto the government portal that was distributing the testing kits at that time, but because NACAS was not providing care, I was not allowed, I couldn't get access to that. The idea was that if we were able to get access to those kits, then we could get, we would get quantities of them and ship them out to members who are having trouble getting the kits. But yes, there are, I think, several instances where members were having trouble getting access to the testing kits. Certainly at the start of the pandemic, it got better.
Finally, in regard to lessons learned and recommendations, you have identified in your statement some areas that went well. And I just wanted to ask you if you could perhaps provide us with a few examples of those.
I'm sitting here and I'm struggling to think of an answer. But I mean, it wasn't. It certainly wasn't all bad. I think the vaccine rollout was, I think, is a good example of things that did go well. That was done very, very quickly, even though there was there was some reluctance on some people not to get vaccinated. But I think that the government should be commended on the speed in which the vaccine rollout was implemented. I think that's probably the biggest spotlight I could shine on something that did go well.
And then in terms of looking to the future, you've identified some key objectives that you think are important. Perhaps you could explain what they are.
I mean, moving forward, I think I'm probably repeating what a lot of other people have said sat in this chair, but we need to give proper recognition to our workforce, and that would be my biggest recommendation is let's get our amazing workforce properly recognised. Dare I say it, properly paid and remunerated. We need to do more around the narrative of how brilliant being a care professional is, rather than concentrate on the negative side of care working. That for me, moving forward, would be job done. If we can get our amazing workforce, I keep calling them amazing because they are. I mean, they're the ambassadors for their providers. They're out there doing the job 7 days a week, 365 days a year. We need to give them that respect. Can I say that? They need to be respected and recognised as the amazing people that they are. And then I can't, I mean, it might seem silly and a little bit simple to say those things, but that's what I would love to see moving forward, is that focus given to our workforce and being brought up to the same level as our colleagues in the National Health Service. We need it. It's far too long overdue.
Thank you, Mr. Featherston. My lady, those are my questions.
Thank you, Ms Hans. Ms Peacock. Ms Peacock's over there. Just a few more questions.
Thank you, my lady. Good afternoon. I ask questions on behalf of the Trades Union Congress. My questions are on the topic of regulation in the care sector during the pandemic. You refer in your statement at page 41 to the decision of regulators to pause routine inspections in care settings in March 2020. And you explain that the CQC continued to inspect in response to immediate risks and concerns about safety as identified by staff or members of the public. But this totaled just 50 inspections between 16th of March 2020 to July 2020. My question is, what do you consider was the impact of this reduction in inspection activity upon the safety of care settings?
I mean, I think to reduce inspections during the pandemic is reverse psychology. I think during a pandemic there should have been more inspections. I mean, and I suppose even if those inspections, when we were not full inspections, but there was some level of inspection throughout the course of the pandemic, that would have been very, very useful. And also, the CQC needed to be more supportive during the pandemic, because we have members who have, it's in my statement, I think, we've had members saying that the support from CQC was not as it should have been. So the impact would have been severely felt. I mean, if they are going to cut back on inspections, that to me is a detrimental step. There should have been more, not less.
And when you say that there should have been more, are you able to elucidate why that would have been? Why during a pandemic inspections are particularly important?
Well, I think it would have been a vehicle to raise issues and concerns about whether an establishment was failing to meet a certain standard, for example. This is just my view, as I've been asked a question today, but I just think that rather than minimise the amount of inspections, they should have been more, even if they were slightly redacted inspections, because I think that would have had a bit of more of a positive impact on the provider. It would have been. I just think, in general, it would have been better if more was done in terms of the inspections. I hope I'm answering your question for you.
Thank you. And in addressing why routine inspections were paused during the pandemic, Mary Cridge of the CQC set out in her supplementary witness statement that the CQC do not want to put our employees or anyone that we came into contact with at any greater risk than they already were. However, you mentioned in your statement that the significant reduction in on-site inspections inevitably placed care home residents at greater risk of harm at a time when they were particularly vulnerable, and you've just explained some of that risk. Was there a failure of the CQC and other regulators to recognise and to balance the risks involved in significantly reducing on-site inspections as against the risk of transmission potentially associated with on-site inspections taking place? In essence, should more emphasis have been placed on mitigating the risk of transmission so that the inspections could take place?
I think so, yes, but then that's a difficult balance to try and get to. But there should have been a. I'm trying to say the balance between the risk of infection and the non-risk of infection needed to be looked at. I think I can understand Mary Cridge's statement saying she wanted to protect the staff, but the people in the care homes themselves wanted to protect their staff. So surely between them, there could have been some middle ground that could have been reached that, yes, there might still well have been transmission, but could it have been reduced? Possibly. So that's why that's my initial thought there, is more should have been done, more engagement, and maybe, I don't want to use the word failure, but maybe there should have been that collaboration between the CQC and the providers as to what can we do together to make sure that you're still getting inspected and mitigate the risk of transmission. I don't think that was done.
Thank you. And turning to look at future pandemics, Mary Cridge has stated in her evidence that in the event of a future pandemic, strenuous efforts should be made to protect the ability to carry out on-site inspections as much as practically possible. So my question is, do you agree that strenuous efforts should be made to maintain in-person inspection activity in a future pandemic? And do you have any reflections on how that may be achieved? Is it an issue of planning and preparation, for example?
I think that's exactly it. I think it's preparation and planning. There needs to be I can refer back to my previous answer, that there has to be that aligned thinking around protecting the staff of the CQC staff, but also the residents and staff within the care setting itself. And maybe that was lacking during the pandemic, and that needs to be looked at moving forward, so that care providers are not left wondering about when the next inspection might be because it's a pandemic. But also, may I say, that when care providers are asking for guidance and support from the inspectorate, they don't get told, we're not here to give advice, or things of that nature. That simply doesn't help the situation at all. And places everybody on a, it's just not an acceptable situation for that to happen.
And just by way of short follow-up, Mary Cridge, I think, has suggested that inspectors should be treated as key workers from the outset of a future pandemic, and that they should be given priority access to testing, PPE, vaccinations and IPC training. Is that a recommendation you and your members would support?
I think that's a good point. I think they should, if they're going to be out there doing the job in the pandemic, then absolutely they should be able to get access to that equipment.
Thank you. I'm grateful, my lady. Those are the
Thank you,
questions.
Ms. Peacock. Can I ask a question? It sounds as if you might have your experience in social care was in Wales, was it?
Correct, my lady.
Bit of a clue in the accent, I think. You've said your membership is 60% English and the other 40% around the devolved nation.
Yes.
You haven't actually specified any differences around the four nations of the United Kingdom. Did you detect any particular problems that were more prevalent in England or more prevalent in Scotland? Or
I didn't detect anything along those lines during the pandemic, my lady. No. The members who contacted us throughout the pandemic would have been across the whole of the UK, but I can't sit here and tell you. I can say, well, this happened in Wales, this happened in Scotland. Each of the devolved governments reacted slightly differently to the pandemic. I think from a personal level, I think the Welsh Government did a reasonably good job. But I can't give you a specific example of differences in the regions as a whole. Sorry.
No, I'm very grateful. That was what I detected, that actually the concerns you were hearing seemed to be replicated around the United Kingdom.
Yes.
Is really the impression I got from your evidence.
Yes, they were. I think that's a fair comment, yes.
Well, thank you very much indeed. That completes all the questions we have for you. I've received a number of messages during the course of this module, and I can promise you that the message I've received particularly loud and clear is the message you wanted to get across, which is the importance of recognising the social care workforce. And if I might say so, you asked if you could be proud of setting up the association. You should be rightly proud. It was obviously a gap that you foresaw long before many others had. So thank you very much for all you've done to try and get the care profession recognised, and it is certainly a message I have received.
Well, that's very kind of you, my lady. And I just finished by saying, can I thank my lady's inquiry for giving me the opportunity to give a voice to our workforce. Very grateful.
Thank you very much indeed, Mr. Featherston.
Yeah, absolutely. Get you some more.
My lady, may I call Professor Hatton?
Thank
just
you,
on his
Mrs.
way in.
do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
I hope we haven't kept you waiting, Professor.
Not at all, my lady.
Thank you, Professor Hatton. You are here today to assist the inquiry with regard to the specific position of people, adults, with learning disabilities in the social care sector. To that end, you have produced, along with Professor Richard Hastings, an easy-to-read report and a full report for the inquiry.
Yes, that's correct.
And just for the assistance of those following, the easy read report is at INQ 00616456, and the full report is at 000587 In terms of your professional background, you are a Professor of Social Care at Manchester Metropolitan University.
Yes.
You set out within the report a very impressive and extensive list of both your experience and qualifications. Perhaps if I can just draw these two out. From 2013 to 2019, you were the co-director of the Public Health England Learning Disabilities Observatory.
Yes.
And you are also a senior investigator at the National Institute for Health and Care Research.
Yes.
Your co-author, Professor Richard Hastings, is also in attendance today.
He is.
He is a Professor of Psychology, Health and Social Care. He holds the 125th anniversary chair in the School of Social Policy and Society, alongside being the Director of the Intellectual Disabilities Research Institute, IDRIS, at the University of Birmingham.
He does.
Thank you. If I can turn then, please, to the report. Just dealing with methodology for a moment, much of the report draws on the coronavirus and people with learning disabilities study, a study that you and Professor Hastings undertook.
That's correct.
Thank you. And that tracked the lives of adults with learning disabilities across the UK at 4 points during the COVID-19 pandemic, the first of those in December of 2020.
Correct, through to late 2022.
Indeed, thank you. If I can ask you, first of all, please, what is a learning disability? How is it defined?
A learning disabilities is the term that's used in the UK. Internationally, the term intellectual disabilities is quite often used. I think a really important thing to point out is that a learning disability is not a health condition. It is, as it says on the tin, it's an issue with learning new things. There are three elements to common ways in which learning disability is classified or identified. One is about an issue with cognitive ability, quite often measured through IQ testing. The second is an issue with managing the kind of functional tasks of daily life. So that might be from things like kind of reading and writing, getting around, being able to care for yourself, social skills. And the third element is that it is a condition, a diagnosis, an identification that happens during childhood to distinguish it from cognitive impairment due to dementia or traumatic brain injury.
Indeed, and to put it another way, it's a lifelong developmental condition.
Yes.
Thank you. In terms of health needs, we've heard already from Professor Banerjee in relation to individuals with dementia that you should not treat effectively that group as one homogenous group. Obviously, quite differences within it. To that extent, what do the needs and the extent of the disability vary?
Yes, so we're talking probably over about 1 million adults with learning disabilities across the UK. So any group of 1 million adults is going to be incredibly diverse. The way that people's needs have been characterised, some of the terminology some people might find offensive is in terms of how severe a person's learning disability is. Typically from sort of mild to moderate learning disabilities. So most people with learning disabilities have this designation of mild to moderate. People will usually be living fairly independently, maybe with some support, and that's distinguished from people, the smaller number of people with moderate to severe to profound learning disabilities. And that characterisation, people normally need a lot more support with kind of daily living, and they are people who are much more likely to be getting adult social care services in the UK.
Indeed, and within your report, you point to one of the issues being identification of those with learning disabilities, and that it follows from effectively the level of need that a higher level of those individuals with more severe learning disabilities will be known to services.
That is correct. So overall, probably only about a quarter of likely adults with learning disabilities are known to health and social care services. So there are large numbers of adults with learning disabilities who don't get adult social care support most of the time, but under conditions of emergencies like a pandemic, some support might be needed, but those people will not usually be known to any health or social care agency.
I'm going to move on to that in just a moment, but just continuing, if I may, just on need for one moment. There are also those with profound and multiple learning disabilities within that group, is that right?
Yes, and people with profound and multiple learning disabilities need pretty much round-the-clock support. Many people are still living with families at home, but with extensive support coming in, rather than necessarily living in kind of care homes, which I know have been discussed a lot in this inquiry. But there's a real importance for that group of ongoing therapy and support, because in the absence of that, there might be permanent damage that's caused without that kind of therapy being available.
Forgive my interrupting. You said there were three criteria for coming within the category of having a learning disability, one of which was a diagnosis during childhood.
Yes.
But you've also said there are 1 million adults across the UK with learning disabilities. Does that mean it's 1 million diagnosed? Or is that your best estimate if they all came within your purview?
Yes, it's 1 million is the best estimate. There are much higher numbers of children identified with learning disabilities in education than there are in adulthood. So there's something called a transition cliff, where many children identified in education systems don't then go on to be identified in adult services. But the 1 million is our best estimate, yes.
Because the reason I ask is because you said 1 million across the United Kingdom, but only a quarter known to the health and social care authorities. It just seemed to me that if there was a diagnosis, why are they not known?
Yes. No, that's based on research, based on prevalence estimates,
right.
Going out and assessing people directly.
Thank you. Sorry to interrupt.
No, not at all. I wish to turn now to focus on the interrelationship with adult social care within the United Kingdom. In that respect, can I please call up the Easy Read report? We're aware that a number of individuals with learning disabilities are indeed following today's proceedings. If I can go to page 4, please, of that. And this sets out essentially a profile of what is known about those adults with learning disabilities and the types of care that they do or do not receive. So the first aspect is that most adults with learning disabilities do not get support from their local council, otherwise known as social care. Is that right?
Yes, that's as we've discussed.
Indeed. Turning to those people that do get social care and support, the majority of those are aged under 65.
Yes, the vast majority. So it's usually over 80% of adults with learning disabilities getting social care are under 65.
And just to place that in some level of context in relation to adult social care generally, it's about 18% of all adults receiving adult social care have learning disabilities.
Yes.
Typically, again, looking at the demographic profile, the age profile, they were typically younger, those individuals with with learning disabilities, with 88% of those adults being under 65.
Yes.
Thank you. In terms of where individuals live, as we see here, the majority of adults with learning disabilities depend on family for some form of their care, often living with their family or receiving support from their family.
It is the most common living situation for adults with learning disabilities who are getting social care, living with family, parents or siblings.
The next most common is living in flats or shared housing or supported living.
Yes, correct. And that's an expanding number of people.
Indeed. And then expanding again, we have those individuals that use day services or take part in community groups.
Yes, so those services are often available to people in a wide range of living situations. So yes, but they're a really important part of adult social care for this group.
Indeed. And what's not included in the Easy to Read report are those numbers that live in residential, the people that live in residential care. And just dealing with that, it's quite a small part of that population. It's around
Yes.
16% of
Yes.
those aged under 65.
Yes, it's relatively small and it's decreasing over time.
And that compares to those over 65 who live most commonly in care homes, those adults with learning disabilities, and those numbers are increasing over time.
Yes, and there may be some adults with learning disabilities, some older adults with learning disabilities in general care homes who aren't identified as a person with learning disabilities or having those needs.
With regard to the social care services that are provided across the United Kingdom, there is it varies depending on geography and areas of social deprivation. That sum it up.
Yes, I mean, there's not good evidence in terms of comparing across the different parts of the UK, but there is consistent evidence of variation within countries. So different local authorities have different levels and profiles of the kinds of services that they offer to adults with learning disabilities.
Indeed, moving to data more generally, in terms of data, how good is the data with regard to adults with learning disabilities and social care? No, I appreciate it's a broad question.
I
A
think
snapshot.
in the context of the pandemic, I think there are kind of two answers to this. One is the data are not good at all. It's really hard. There aren't consistent tracks of data over time. There's not consistency across countries. There's real issues with the reliability of what's recorded when there are data systems. So I think that's one set of things. But having said that, I think in the context of the pandemic, there was clearly enough evidence and enough data there to make informed policy decisions in terms of pandemic planning before the pandemic.
And just picking up, if I may, on each nation and the way in which data is collated, it's not consistent across the four nations, is it? So that poses its own challenges.
No, for some people it's people known to services, for some it's people getting kind of long-term care. There's differences in the minimum age, there's differences in kind of how that information is collected and how often, so they vary hugely. And in some places there's currently not being any data collected at all, for example in Scotland.
Indeed. So in Scotland, there's been no data on social care services received by those individuals with learning disabilities since 2019.
That's correct. And I think, again, this is thinking forwards, that I know there's been a lot of discussion of data in this module, but recommending a new data system will take years. So I think there needs to be something around data that is more immediate and short-term and pragmatic than that as well.
Indeed. And you do set out some of those recommendations towards the end of your report, and we may touch upon those later. But if I can just pick up also on Northern Ireland, because Northern Ireland in particular has significant data limitations. And if I may call up the statement of Joanne Sanson, please, paragraph 97. What we see here is she records, on behalf of Disability Action Northern Ireland, the sheer absence of data within the care sector is shockingly demonstrated by the fact that during the pandemic there were not even accurate figures of the number of adults with a learning disability receiving health and social care in Northern Ireland, instead relying on old estimates all the way back to 2015. And we've also heard evidence in the course of this module from the Chief Medical Officer of Northern Ireland, Professor McBride, who explained it was not possible to disaggregate data, including by adult social care. What challenges did those pose in monitoring? Well, first of all, identifying those with adult with learning disabilities, and secondly, in monitoring the impacts of the pandemic.
Well, it makes it impossible to identify people, and that makes it then very difficult to track any impacts of the pandemic. So the only sort of continuous data series over a length of time kind of before and through the pandemic is probably England. And in England, we found that the number of adults with learning disabilities getting social care dropped during the pandemic. But there's not sufficient continuity of data across other parts of the UK to be able to draw any firm conclusion. And that's a real problem when you're trying to understand the impacts of policy or practice in different parts of the UK.
Indeed, and a further example you give within the report is that there's no public data on mortality, so deaths among adults with learning disabilities in Northern Ireland also. Is that correct?
Yes, there wasn't anything produced that we know of during COVID about COVID mortality or all-cause mortality in Northern Ireland. I mean, Northern Ireland is smaller in terms of population, which might present some challenges in terms of the sophistication of the analyses you can do. but it's clearly sufficient people to be able to draw the conclusions you need to make policy choices.
And in terms of collation of data, what might that look like in terms of a good quality data? What does it mean? You said, and we've heard many times, we need more data, or data's insufficient, but what does good look like in this context, and what is needed in this particular context?
I think in this context, the first thing is to work out the purposes for which you want data. I think a blanket, we need more or better data, doesn't really help anybody. So I think having a clear set of purposes of what you need the data for is step one. I think then there's something at looking what the data are that are available, whether you can link them, whether you can actually disaggregate them, what that gives you that enables you to answer some of those policy questions or planning questions you have. And then it'll be a question of working out how to fill in the gaps. I think there are basic things like consistency, reliability of coding. So, for example, in GP systems, they don't reliably record the ethnicity of adults with learning disabilities. That's quite a basic thing. So I think some of it is we can really improve and fix what we have and make better use of it. And that, I think, is you might have some more immediate protocols for use in terms of pandemic planning and then pandemic action than you would by staking everything on building the perfect data set at some point down the road.
Thank you very much. My lady, this may be a convenient moment.
Yes, of course. I hope you're warned that we take a regular break. I shall return at 3:15. Cecil.
Indeed. Professor, may I now turn to the impact of COVID-19? And again, call up, please, the Easy Read report, page 5. It's INQ0006. Thank you very much. And these are the headlines, ultimately, aren't they, in relation to people with learning disabilities. And so as we can see here, that during the pandemic, people with learning disabilities were firstly more likely to get COVID-19 than people without learning disabilities. What did your research demonstrate there?
That's correct. The evidence that we found, there's actually quite good evidence in the UK about the deaths of people with learning disabilities during COVID internationally. They found that during the earlier phases of the pandemic, before the vaccine was widely available, people with learning disabilities, adults with learning disabilities, were between 7 and 10 times more likely to die from COVID-related issues compared to people without learning disabilities. Even with the advent of the vaccine, absolute death rates for people with learning disabilities from COVID dropped, but there was still that disproportionate gap in the risk of COVID death between people with learning disabilities and people without learning disabilities. So this was a very stark difference that remained throughout the pandemic.
Indeed, and we see that, don't we, at the very end of this page, where it says that individuals with learning disabilities were much more likely to die from COVID in that regard. And you've given some of the statistics. In the first wave, I think it was overall, it was an 8.69 times more likely to die. The second wave, approaching 7 times, as you said, more likely to die. And you explain later in the pandemic that risk decreased. But it was still between 4 to 10 times more likely than those without learning disabilities. What does that mean? Why do we have that range there, 4 to 10 times?
The range is usually about methods, because of all the issues that we've talked about with data, about identifying people with learning disabilities, about how people use different, whether people are dying in particular kinds of services. There are different ways to do that, so you get that range. I guess what you get is a very consistent pattern of increased risk of death, and that is particularly high from the evidence that we have among people with Down syndrome within the group of people with learning disabilities.
Indeed, and that's one of the further disproportionate impacts, isn't it? There are other aspects or risk factors that come into play, one of them being, as you say, Down syndrome. Others mirror what is known more generally about COVID and disproportionate impacts, for example, on men, age being a significant risk factor, minority ethnic individuals also facing greater risks, and then multiple health conditions, and in particular those with profound and learning disabilities that we were talking about earlier.
Yes, I guess one thing I'd say on the age front is that the peak age of death from COVID for people with learning disabilities was younger than for the general population. So the peak age was sometime between 50 and 64 years old.
Thank you. And with regard to other aspects that feed into that, as we've seen from that the Easy Read report, those individuals with learning disabilities were more likely, firstly, to get COVID, as in to be infected.
Yeah, sorry, I realised I did answer a different question to the one you asked a little bit
Not
earlier.
not at all. It's the headline point from the report, ultimately.
So people were almost twice as likely to be infected with COVID. People were also more likely to be hospitalised with COVID. But once in hospital with COVID, there's one study suggesting that people were less likely to get active COVID treatments in hospital compared to other people with learning disabilities were less likely to get active COVID treatments in hospital compared to other people with COVID.
Indeed. And you set out the various statistics within your report. I won't go into detail with those now, but they were less likely, for example, to receive non-invasive respiratory support, intubation, less likely to be admitted to intensive care units, and overall, there's a 56% increased risk of dying after they were hospitalised compared to those individuals without learning disabilities in hospital.
That's correct, yeah.
Thank you. In terms of the risks of death, as we've obviously just gone through some of those aspects, but if I can just pick up one further aspect there, and it relates to one specific risk factor, and that is in relation to care homes. You explain within the report that UK evidence is relatively limited, not least because there are relatively few adults with learning disabilities that reside in such settings.
Correct.
But what does the evidence that you do have to show or demonstrate?
The evidence showed that living in what's described as a congregate care setting or residential nursing care home was associated with increased risk of death for adults with learning disabilities compared to adults living in other situations.
Did that remain the case throughout the pandemic, or was it limited in time to any of the waves?
No, it was a consistent finding throughout the pandemic.
And now, if I may look at it through the other end of the telescope and in a broader sense, and just place that, please, within the context of deaths in care homes more widely. Obviously, increased risk for those adults that were in care homes that had learning disabilities. But compared to the broader care home population, they were at less risk than others, than those in older people's homes. Is that right?
That's correct. And again, I think one of the big differences in care homes that tend to be registered for adults with learning disabilities versus care homes for older people is that they're much smaller in terms of the number of people who are living in those care homes. So the average is something like 9 or 10 adults in a care home as compared to, perhaps 40 or more in care homes for older people.
Indeed, and you set that out within a table within your report. It's at page 14 of your report, and we see that the picture is similar. So this relates to the position in England, and so we see here the care homes without nursing registered for older people, as you say, with learning disabilities compared to those registered for older people. If we go down, average number of places per home, 9.8 for those with learning disabilities, 30.2 for those for older people. And although the numbers increase, there is still a differential when it comes to care home with nursing. If we go across, for those individuals with learning disabilities, it's around 38.2 places per home compared to 54.2 places for those that are older without learning disabilities.
That's correct.
Thank you. And in terms of your research, are there any features of smaller homes that you can point to that you consider decrease that risk? Is that something you can comment on?
Well, I think it's a general feature that smaller care homes reduce risk of COVID transmission in a wide variety of ways. So it obviously reduces the number of people who you are kind of with every day. It reduces the number of staff who are coming into the home. So I think all those things help, and easier to negotiate, I guess, a kind of restricted life if you have smaller numbers of people together.
Thank you. And then just dealing with a connected matter, which is all-cause mortality. What was the position immediately prior to the pandemic in that regard?
So before the pandemic, consistently, people with learning disabilities were more likely to die from all-cause mortality than other groups of people. So that was an inequity that was kind of well established and not really shifting beforehand. During the pandemic, all-cause mortality actually disproportionately increased for people with learning disabilities compared to other groups. So that existing inequality got worse.
Indeed, by May of 2020, it had doubled effectively
Yes.
that in 2019.
Yes.
If I may now just touch upon, please, the position of vaccinations for those adults with learning disabilities. The inquiry has heard fairly substantial evidence in relation to this, both in modules 4, but also in relation to the healthcare module, module 3. And for these purposes, by December of 2020, the vaccination programme for rollout had been updated in terms of prioritisation to include those clinically extremely vulnerable individuals in a banding along with those individuals who are aged 70 and over.
Yes.
That also included Down syndrome
Yes.
and those with severe and profound learning disabilities. Is that right?
People with severe and profound learning disabilities, I think, were put into band 4. The issue there, again, as we've talked about before with data, is that that would have to be based on GP records, and GP records do not consistently or reliably record that at all. So making that a requirement in terms of having to specify that group would have led to a huge amount of bureaucratic gatekeeping, which would be completely counterproductive in a pandemic when the evidence was quite strong that it's people with learning disabilities as an entire group who are at increased risk. So the position they eventually came to, which I think makes sense, was everybody registered with a GP as a person with learning disabilities will be placed in that priority band 6, sorry.
No, not at all. So there were practical difficulties in the initial instance, but certainly within the report, as the pandemic went on, you point to that as being one of the success stories and points of learning in terms of the actual rollout to individuals with learning disabilities. Is that right?
Yes. So in the end, we have data for England showing that rates of vaccination for adults with learning disabilities was actually slightly higher, if anything, than for other groups of people. And we did see a very proactive mobilisation of vaccination efforts that were reasonably adjusted to people with learning disabilities as is required in the Equality Act. But there was a fantastic mobilisation of vaccination efforts, which really stood out as being different, I think.
And some of those different mobilisation efforts included proactively going to those individuals' homes for vaccination purposes.
Absolutely, yes. And that will kind of wouldn't normally happen, but yes, there was, visiting homes where there'd be groups of people and vaccinating everybody at the same time where you could. There's a small minority of adults with learning disabilities, often people with quite complex needs, people with profound and multiple learning disabilities, for whom a vaccination is not possible for various reasons. This might be on health grounds, or it might be a very severe needle phobia. And I think there's a real issue about what happened in the pandemic to that group of people.
Indeed, and certainly some of those issues have been explored previously at length. If I can now turn, please, to turn back to the Easy Read report to page 8. Pre-pandemic, there were known issues with do not attempt cardiopulmonary resuscitation notices in relation to adults with learning disabilities. Is that right?
Yes, there was quite consistent evidence from the Learning from Deaths review and from other sources that quite high proportions of adults with learning disabilities who had died had a DNA CPR. These were reviewed by local health service staff, and a proportion of them were found to have been completed without due consultation. And this fitted with consistent stories that were coming up about kind of people discovering a DNA CPR on their relatives' notes when they were in hospital without them knowing how that had got there.
If I can just interrupt you, you say this fitted with the stories that you were hearing.
Yes.
Do you mean in relation to during the pandemic?
Some of that was before, but it was potentially there was some evidence that during that increased.
So that was going to be my next question, is what was the impact during the pandemic? And what we see here is that in the pandemic, some people with learning disabilities had DNA CPR in their notes, but they or their family had not agreed to this.
Yes, that is the case.
Setting aside the aspect of agreement, in relation to the communication, were there problems with the communication processes that were gone through in terms of consulting families or those individuals themselves?
Yes, people reported quite widespread problems with how DNA CPR decisions would be communicated to them. Again, there was some of that before the pandemic, but there was certainly more of that potentially during the pandemic.
Indeed, and within your report you set out the findings of various reviews, including the CQC, Care Quality Commission. Again, we've heard some evidence in relation to that, so I'm not going to take you there. But just to go to the next aspect, please. It says some groups of people were all given DNA CPRs at the same time. This is not okay. I just want to pick up on one aspect of that, if I may. That in terms of the NHS, they resorted to sending out letters to doctors and healthcare workers to explain that, for example, the terms learning disability and Down syndrome should never be a reason for issuing a DNA CPR order or be used to describe the underlying or only cause of death.
Yes,
And
you wonder why they felt the need to issue those letters, what practice was that led them to issue those letters. And certainly there doesn't seem to be much that we could find that was written down, but people quite consistently reported GP practices, for example, sending around those kinds of letters. Sometimes they were rescinded under challenge, but that was definitely an issue. And again, the sort of the high level issuing of a letter doesn't necessarily mean widespread implementation of that in practice, hence all the reviews from PHSO and CQC and others in other parts of the UK.
thank you. So in terms of the people that you were speaking to and the research that you conducted, were concerns expressed that people with learning disabilities were having those notices recorded solely on the basis that they had a learning disability?
Yes.
More broadly, is it right to say that a large number of people were very scared about the prospect of having those notices put in place?
Yes, they were. I think people had not had the conversation about what that meant. I think people had not had the conversation to then be able to make an informed choice about that. And I think people were concerned that a DNA CPR notice accompanied other things that might or might not happen to them in hospital in terms of health treatments. So people were concerned that that might be a marker of other issues in terms of lack of health treatments that they may get during COVID.
Indeed, within your report then you go on to explain that people and their families did not get easy to understand information about those notices or the process or end-of-life conversations.
Yes,
and
planning.
planning.
This is a consistent feature of people's experience in the pandemic in all sorts of ways.
I want to move on, please, now to other impacts that individuals faced, and the first one being the imposition of PPE and face masks. And certainly in relation to some individuals with learning disabilities, they were exempt from wearing face masks. But for some, it was quite difficult, is that right, for them to understand why they might need to, or indeed experiencing others caring for them with face masks around them.
Yes, so again, we're talking about a very diverse group of people. So I think many people with learning disabilities understood why they were needed, even if it was uncomfortable or really strange in terms of trying to sort of interact and communicate with people who knew you well. Many people who had an exemption still wore face masks anyway when they were out because of their sense of public duty and protecting others as well as themselves. But yes, but for some people, it was incredibly difficult in terms of communication and in terms of heightening how scary the whole COVID pandemic was.
And you will be aware that a number of people were subject to visiting restrictions if they lived in either forms of supported housing or indeed in care homes, or alternatively were subject to restrictions in their own homes during the pandemic as a consequence of the various non-pharmaceutical interventions put in place. If I could just call up, please, the Every Story Matters record for this module. It's INQ 000587564 at page 50. This records the account of an individual whose son was in a residential care home with severe autism and learning disabilities. She explains that she was unable to visit him. They couldn't visit through a window or FaceTime because he would not understand and so become upset. It was a choice between keeping him calm or upsetting us all by seeing him through a window. Do those experiences resonate with some of what you've also found during your research?
Yes, the research that we did, this is not an extreme or particularly unusual, heartbreaking story. And there are stories that people have very much like this in a whole range of situations, and that have, I think, quite a lasting impact on people. That those experiences and those memories are still quite raw for people if you ask people about them now. So there is a real sort of long-lasting impact of those restrictions and how they were handled and how they weren't particularly adjusted for the circumstances that people with learning disabilities found themselves in.
Thank you. And on the converse side of that, we also had difficulties, we've heard evidence of people who are living at home and are very frustrated because they're not being allowed to go out, and the problems that caused within their own home and those individuals that were caring for them and the relationship breakdowns that took place. Is that also a feature?
Yes, absolutely. So people's worlds became incredibly small. Often, we'll come to this, but social care support was withdrawn or severely reduced. Many people did not really understand why they couldn't go out. I should say, in terms of some of the early advice on being able to leave the house, again, early advice and guidance was only once a day for everybody. That was subject to legal challenge, and that was changed for people in some groups, including people with learning disabilities. So again, I think that's an example of how the lack of consideration of adults with learning disabilities led to a period of distress that was completely unnecessary, because if that guidance had been written in that way in the first place, it wouldn't have been an issue.
And that's one of your overarching recommendations, isn't it? Is that there needs to be accessible guidance for individuals with learning disabilities and their families and friends who are caring for them.
Yes, so NHS England has had an accessible information standard since 2016 that applies to health and social care services. They refreshed it in June 2025, partly because it hasn't been implemented. So some of the building blocks are there, they're just not being used.
Indeed. More broadly within your report, you set out in quite some detail the impact of the withdrawal of services, care, support, and more broadly social care provision during the pandemic. And you also set out the impact of that disruption to routines, but also physical impacts, cognitive impacts, and indeed behavioural and emotional impacts. And we've more broadly have heard evidence in relation to the impact upon individuals' health and well-being. And similarly, in relation to family carers, we've heard evidence of the very substantial impacts on those, concerns of physical and mental health. And your report mirrors that, doesn't it, in terms of identifying burnout, anxiety, isolation, fear, and a sense of abandonment.
Absolutely.
Can you just expand on the sense of abandonment? Because I know that's another area in which you feel strongly that there needs to be some form of future planning and rebuilding.
Yes, so people with learning disabilities and family members quite often, and we'll talk about today, that's the importance of that sense of being abandoned, just being left on your own to get on with it, with no warning. Sometimes this felt like it was overnight. There was no sense of transparency or fairness, and no sense of when things might ever come back. And again, they haven't yet come back, as far as we know, to pre-pandemic levels, which is at the end of a decade of austerity anyway. And I think that abandonment is really important for this inquiry, that the loss of trust that people have in services and in governments to help them when the chips are really down. And I'm not sure that governments and social care services have really appreciated the job they have to rebuild that sense of trust. That in the absence of that, that's going to make a lot of other things that governments and services are trying to do a lot more difficult.
Indeed. And then finally, if I may, within the Easy to Read report, you set out very clearly lessons learned, things that you have learned, and then in terms of recommendations, things to do in a future pandemic, and then separately to that, things that can be done now. If there was one overarching recommendation or message to take away from your evidence today, what would that be? The most important one.
Yes, I think what we've been discussing is how many of the building blocks are there, and they weren't perfect, but in terms of information, in terms of aspects of systems, in terms of guidance, that was some of that. Enough of that was there for policymakers to really plan properly for a pandemic. So there is no excuse for government to say that they don't know where adults with learning disabilities are in terms of social care services. It's no excuse for them to say they have no information. We know that people with learning disabilities are at vast increased risk of health inequalities, for example, that will make a massive difference. So the real issue is that there was nobody who was picking up those threads and turning it into pandemic planning that was national and that could be then thought of in a local way. So I think our main recommendation is to find a mechanism and find a way for people with learning disabilities, family members, to be closely involved in some kind of way to do coherent pandemic planning that has some kind of clout institutionally, that has some kind of independence, that has some kind of transparency so that people can trust in it. And I think that would find a lot of things that can be done in the short term. We've got a lot more sort of specific recommendations in there, but without that kind of drawing together and that sense of urgency, I think all those threads would be lost.
Thank you very much. My ladies, those are my questions, but there will be some more questions for you. So.
There are. Just before Ms Beattie asks her questions, can I ask you the same question I asked the previous witness? Your report does cover England, Wales, Scotland and Northern Ireland. Were there any particular discrepancies or better practice, worse practice in any of the nations that you or your colleague, Professor Hastings, wish to emphasise?
In terms of the experiences of people through the pandemic, in a way, to our surprise, there weren't really big differences across different parts of the UK because they have quite different systems when it comes to adult social care. But we didn't find particularly big differences. I think there are some differences in how responsive national governments were. So, for example, in terms of vaccination, the first country to decide that everybody with learning disability on the register would be prioritised was Scotland. So devolution helped, I think, in terms of Scotland having the leeway to do that. But there were not big differences in people's experiences of services, which was something that we were exploring.
Thank you very much. Ms Beattie.
Thank you, my lady. Professor, I ask questions on behalf of disabled people's organisations, and the questions concern Care Act easements and reductions in services. In your report, you touch on Care Act easements as an example of legislation during the pandemic with particular relevance to adult social care for adults with learning disabilities. And you've explained earlier in your evidence how adults with learning disabilities use social care. You say in your report that the local authority adult social care responses to the pandemic did not seem to map onto whether local authorities had used easements or not. So my question is, did that reflect that only a few local authorities were actually formally using easements, while others seem to reduce services without formally using them?
Correct, yes. So in terms of geography and in terms of time, many more people were experiencing those reductions in adult social care services, whether they were in an easements area or not. And did the fact that it didn't seem to map on to what local authorities were doing, and there seemed to be a disconnect there, did that reveal a lack of oversight and transparency around those reductions in services? I think we don't really have much evidence to speak to that, but I think I can say the experience of adults with learning disabilities and family members. They experienced it as lacking in transparency and lacking in fairness and lacking in due process.
And I think you said earlier that people, for example, with profound and multiple learning disabilities who may live at home with extensive support coming in might suffer permanent damage if that support was reduced. Is that the kind of impact that was experienced?
Absolutely. So people with profound and multiple learning disabilities are quite a small group in terms of number, but in terms of support they need quite extensive support. And that's exactly the kind of thing where there's a permanent impact. So, for example, postural care. If you're a person with scoliosis and you miss out on 3 years of postural care, that might be damage to your spine, which no amount of future postural care will completely correct.
And would it be of benefit to have greater transparency on, in a future pandemic or in any event, on reductions to services of that nature?
Absolutely, yes. I'm always in favour of transparency, and I think one of the things we can do around data is set protocols for publication of data, of evidence in advance, so that we know exactly when things are going to be published, because otherwise you can get delays in publication and people start to question why those delays are happening. I think protocols on transparency, what data is going to be released when in advance, I think that will really help in terms of transparency.
Thank you, my lady.
Thank you very much, Ms. Beattie. Very grateful. Professor, that completes all the questions we have for you. Thank you very much indeed. And I think Professor Hastings, sorry. Oh, Professor Hatton.
With
Professor
the same
Hastings is
person,
also
really.
sitting here. Somebody whose name begins with HA as well. I should have got that right, shouldn't I? Thank you both very much indeed for the help you've given to the inquiry in preparing the report and the easy reading report, which is obviously a great help, particularly for this particular aspect of our inquiries. So I'm really grateful to you both for your help and for coming today.
Thank you, my lady.
Very well, that completes today's hearing. I shall sit again at 10 tomorrow morning.
All rise.